middle in helping get this going. We just wanted to say a few words about PD ECMO. We do have some webinars that we've done in the past that we're going to continue to do quarterly. We have a YouTube channel that you can get to by going to this QR code, and you can see the webinars that we have done in the past. This webinar will be, as you saw, Katie just started recording it, so we will be putting it up on our YouTube channel. And then in addition to the EuroElso team and ESPNIC will also have the webinar on their pages as well too. So you can reach it through a couple of different ways. Katie, you want to next slide? Yep, those are the EuroElso platform and then the ESPNIC platform. So now I'm going to hand it over to Dr. Katie Doan.
Thank you so much, Elise. Hopefully you all can hear me. Feel free to stop me if you cannot. I would like to introduce and welcome our panelists. The first is Dr. Adam Heimbach. He is an assistant professor in pediatric critical care attending at the Children's Hospital of Philadelphia. Dr. Katie Moynihan, who is an assistant professor and attending physician at Boston Children's Hospital. And Mara O'Callaghan, who is the lead ECMO and VAD nurse specialist at Great Ormond Street Hospital in London, England. And Dr. Peter Roeleveld, who is a EuroElso steering committee member and a medical director of the PICU and Leiden University Medical Center in the Netherlands. Welcome. Thank you all so much for joining us. First, we have our, as Elise mentioned, we're very excited to be able to offer CME credit today for this session. So if you follow the instructions you see on the screen, you'll be able to claim CME credit today by texting this code to this number. And you can also see the relevant financial disclosures here on the screen. And if you miss this information, don't worry, Elise will post it in the chat and we will share it again at the end of the session. Today, we have 5 challenging ECMO candidacy cases and accompanying questions for our panelists. We will be polling the audience throughout the cases to see how you would handle these difficult ECMO candidacy decisions as well, using Poll Everywhere. And then hopefully we will have some time at the end for a little Q&A for our panelists. The first patient is a 12-year-old male who was found submerged in a pool for an unknown period of time. He had 20 minutes of CPR prior to ROSC at an outside hospital emergency department. Upon initiation to the PICU, he required mechanical ventilation, vasoactive infusions, fluid resuscitation, treatment of coagulopathy, and anti-seizure medications. 36 hours after his admission, he developed worsening respiratory failure, requiring ventilation in vent settings. You can see vent settings below. And if you all don't mind muting, if you are not intending to speak, if you don't mind muting. Oh, back one slide. His vent settings required escalation, and he had an oxygenation index of 35 at that time. He was on an epinephrine infusion, and his neuro exam was significant for equal and reactive pupils with no cough or gag reflex noted. He was having frequent seizures on EEG, requiring escalating anti-seizure medications, and the family did express wishes for everything to be done at that time. So we first want to hear from you using Poll Everywhere. Would you put this patient on ECMO for the respiratory failure that he has developed? We will give you a minute to answer this question. You can answer the question by texting P Committee 579 to the number 22333. You can also join using the QR code or the website on the screen.
I do want to add that for the Poll Everywhere, you may or may not get a message that you can't submit an answer because it's going to limit us to the total number of answers. So never fear if you for some reason get that message. We're just not able, we've had a great turnout today and probably not going to be allowed to have 140 responses. So anybody who can participate, that's great. Thank you.
Okay, we have a good variety here. Some people need more information. The majority say yes, and some say no. So we will come back to this to hear from our panelists about their opinion. First, here we go. I want to cover this question first. So Dr. Moynihan, or Katie, as she asked me to call her before you all joined. Katie, you recently published a paper in Pediatric Critical Care Medicine entitled ECMO Candidacy Decisions, an Argument for a Process-Based Longitudinal Approach. Early in this manuscript, you asked the question, what do we really mean by ECMO candidacy? And you go on to explain how this has changed a little bit over time. Would you mind expanding on this a bit for the group?
Thanks, and thanks again for the invite to chat with you all about this super difficult decision, as we just saw in the variability of people's responses. So, I mean, to answer or address the first kind of question about what do we mean by candidacy, it's a pretty nebulous and ambiguous term. And so the group of, or the very illustrious team here, including Roxanne and several of my other amazing colleagues, have kind of advocated to be a bit more explicit about what we mean by ECMO candidacy, to determine or to define that as whether or not we think ECMO is going to be beneficial for the patient. And so broader decisions around what should be done regarding initiation of ECMO and also continuation of ECMO. So on one hand, you could say that ECMO candidacy could determine whether or not we're going to cannulate the patient or not, or whether or not they're going to be considered eligible or considered for eligibility for cannulation. And so using that latter consideration that, you know, we should, using candidacy to think about whether or not ECMO is beneficial for this patient or not, in that context, and certainly in this paper, we talk about the fact that everyone should be at least considered for ECMO and have a fair decision about that for them. And so using that latter definition, that's the consideration there.
Definitely. I liked how you described that previously decisions involved what should be done or if ECMO is in the patient's best interest. And now a lot of decisions involve clinical reasonableness, balancing with the family preferences, which I thought was a really eloquent way to state the current state of ECMO candidacy. So I want to turn to the polls of the decision-making process for ECMO candidacy.
Started, and this is, he had written this out and given it to his manager, and his manager had
Sorry, Katie, did we lose you?
No, I was just saying, look, these are super hard. You're right. Like, these are really hard decisions. Yeah.
And Dr. Doan, did we lose you?
I'm still here. I think I might be on a slight delay, so bear with me. Okay. I was wanting to turn to Dr. Roeleveld to ask about some important principles in the decision-making process for ECMO candidacy.
Well, that's thank you. Thank you for inviting me. This is you didn't choose this case for nothing. I think it's a very difficult one, and it's not something that we could decide quickly amongst ourselves. So I was one of the persons who said I needed more information, and I would like to have some more information about the neurology. But first things I always ask myself is the reason that this child might require ECMO, does it actually bridge somewhere? So if we look at the problem, which is respiratory at the moment, I think, yes, we can bridge a respiratory problem. So that would be an indication, and that could be a reason to proceed to ECMO. But the underlying neurology, of course, is what is really, really important here. And that is always so difficult to predict. And we would do that as a team discussion, try to get the opinion of the neurologists and of our team, of the nurses, and then make a medical decision as good as we can. But we know that predicting what the future will hold for these children is very, very difficult. And I find it more and more difficult with the years that I seem to be doing this. So in the beginning, I was far more black and white, and now I find it more and more increasingly difficult to predict what is going to happen. So one of the things I do not understand about this child is that it has reactive and equal pupils, but no cough and gag. So but I would like to know a little bit more about the neurology if we could, although it seems grim after 20 minutes of CPR, but we have seen children survive. So I would ask for a team discussion and make a medical decision. And in Holland, what we would do is, of course, we talk to the parents about this. We listen to their wishes. We discuss our team plan with them. But it's a decision we make together with the family. It's not something that we leave up to the family. So yeah, this is my 2 cents worth at the moment. So I would discuss with quite a few people, neurology team, nursing, to see where we should go.
Yeah, I think you bring up a lot of very interesting points. Making the decision in a team is one important aspect that we'll cover a bit later, and then weighing with the family, but not necessarily asking the family specifically for a decision, but making the decision with them. Mara, I wanted to turn to you and see what you think about this patient's candidacy.
Thank you very much. And again, thank you very much for the invitation. I agree actually with a lot of what Peter said, and maybe all of it. The grey cases that fall into grey areas cause the most consternation and take that careful consideration. And that's where you need your multidisciplinary team, and you need to be discussing it with the family as well. But going right back to the very beginning, I think, again, as I was reading down through this case, it was the first things that came to mind was other information that we would need. And this was a near drowning, but it was unwitnessed. What was the body temperature when that child came up? Was it salty water? Was it fresh water? Just to give us a little bit more indication of where we may go with ECMO support. The European Resus guidelines say that ECMO should be considered to treat cardiac arrest in these patients, and secondary to treat pneumonia or ARDS. But the worrying thing here, as Peter was saying, was that no cough or gag and the neuro complications. So I think, again, talking with the family, finding out, yes, they want everything to be done, but understanding maybe what that means and what that means to them, what the expected outcomes may be and what we think may be reversible and what isn't reversible. So more imaging, more information. And then even if we have the ability to provide ECMO, is thinking about some of the complications that we may fall into as we provide it, and especially with this patient having, I was thinking of coagulopathies, of bleeding, and that may mean that providing ECMO may become very, very difficult. And then whether there are any other contraindications to that support. So going on to ECMO may give us benefit, give the child the benefit of the doubt, if that's what the multidisciplinary team decide and what the family decide as well. And that may allow us time to either bridge to a decision where we get that extra information, so it buys us some time. It may be a bridge for that family to make their decisions, and and if this becomes futile, for them to have a chance to say their goodbyes. And it may bridge us for this child to be a potential organ donor. So there are sort of lots of things in there, but I can just come back to that careful consideration, and these grey areas, these grey cases make it very, very difficult. So candidacy is one thing, and then once you make your decision about whether you're able to provide that support.
Definitely. I think you hint at a lot of the difficult aspects in this case of possibly evolving neuro exam and difficulty knowing exactly what the future will hold. Dr. Heimbach, do you want to weigh in?
Sure. Thank you very much for being invited or for inviting me to be a part of this webinar. I think one of the things I agree with everything that's been said so far. I think one of the things that I think about when I was thinking through this case was, will ECMO allow me to achieve a therapy for those 3 to 5 days post arrest that I'll be able to achieve that I won't be able to achieve with a ventilator? And we've had several instances recently of kids not in dissimilar situations who had either in hospital arrest from status asthmaticus, or there was 2 recently that we had that we did bridge with ECMO in terms of the post-arrest period because we had such toxic ventilator support and not being able to achieve, all the normal tension or normal carbia, normoxemia, all that stuff we try to achieve with post-arrest care. So, my default is the longer I've been doing this, I agree, like the worse I am at predicting exactly what's going to happen. So I think my default here would be, try and give the child the support that he or she needs for those 3 to 5 days, with all the caveats of the risks that are associated with ECMO and, likelihood this may not work. But, my sense is that I would probably give this child at least a chance for that 3 to 5 day window.
Excellent. Thank you all so much for your input. I'm going to move to the next case for the sake of time. Here we have an 8-year-old female with a history of ALL who has just finished the induction phase of chemotherapy, admitted with febrile neutropenia. Her course is complicated. She continues to have fever without a clear source for 3 weeks while inpatient. She's then transferred to the PICU with fatigue and tachypnea and found to have acute LV systolic dysfunction with an ejection fraction of 25%. The etiology of her cardiac dysfunction is unclear, so she's deemed not currently a transplant or VAD candidate by the cardiology team. The medical team then determines that she's not an ECMO candidate. Milrinone, low-dose epi, and BiPAP are initiated. She continues to have pancytopenia with thrombocytopenia. Her vital signs do improve. Her mixed venous and lactate are reassuring, but her echo remains unchanged. On PICU day 4, she has worsening respiratory failure requiring mechanical ventilation with the settings below, with a high oxygenation index of 44. So we want to poll the audience. Looks like we got logged out of poll everywhere. 1 second. While we are attempting to poll the audience, maybe we can go ahead and hear from one of our panelists about the medical team had previously determined this child should not be an ECMO candidate if cardiac ECMO were needed. Now that her primary issue is respiratory failure, would you consider her ECMO candidacy status to have changed? Maybe we can have Dr. Roeleveld weigh in.
Thank you. We would certainly discuss it again, but the fact that she is still neutropenic is a very bad omen and predicts a poor outcome. So again, we would discuss in the larger team, but we have a very high threshold of supporting children with any kind of ECMO who are neutropenic. So we have a stem cell transplant program here in our hospital, and we only consider those if they have regeneration of their bone marrow. So if they have some white cell count increasing. And before that, it's very difficult. So I think in our hospital, we would probably have a high threshold of going on. And if we did, with very good discussion with the family and the team, that the chances are poor, but that we're willing to go for it, and that it will require a lot of time. So again, a difficult one. We would probably tend to go no.
Definitely a very difficult one. It looks like the majority of our audience so far is saying yes. I apologize for the scribbling on the screen. I think that's part of our delay issue. We will give one more second for everyone to weigh in, but it looks like we are nearing more of an even split, which is interesting. Okay. Dr. Moynihan, your paper on ECMO candidacy challenges the notion that a patient's appropriateness for ECMO is a single decision at a single point in time. Can you weigh in on that for us and explain that a bit more?
Yeah, I mean, as Pete already alluded to, and a lot of people have noted, these are super hard decisions that we're making. We're trying to help the patient and their family and not cause harm. We are stewards, and we have a stewardship obligation to consider the resources. We have a professional integrity to use those resources in a way that's, you know, reasonable and clinically beneficial for the patient. And we have this responsibility to advance and innovate. And I think, you know, the fact that Ryan Colvin published a paper using FIS data in 2020 that showed that kids with oncological diagnoses like leukemia and even post-stem cell transplant do have increased odds of mortality on ECMO, but not 100%, is really kind of epitomizes the shift or the paradigm shift in what we're seeing in these candidacy determinations. And so I think the fact that there is so much prognostic uncertainty that you've got 50-50 from the audience saying whether they would go on or not just really underscores why these, or how this is so hard to make these decisions. And things change. So it's not only, you know, over time. So 10 years ago, this would have been, you know, an absolute no in the vast majority of centers. Now it's far more close to 50-50 for a lot of these decisions. And so there's these temporal changes, but there's also clinical changes. And so day to day, moment to moment, things change with our patients that make us rethink things. In on admission for a patient, it might be obvious that they're a reasonable ECMO candidate because they would clinically benefit in the setting of reversible lung pathology or, you know, cardiac myocardial recovery. And then something changes, like they have a brain bleed, they suffer an event which changes things, they become coagulopathic and things like that. And so the dynamic aspect of what we propose in the paper that you alluded to at the start is really that we need to be flexible as a team and roll with the punches and ride that roller coaster of clinical care. And as Pete just alluded to, like revisit things. And so this patient now has a very different consideration. She's got aspiration pneumonia. Arguably, there is a reversible component here from a respiratory perspective. At the same time, there are a huge number of risks associated with providing ECMO support in this patient, whether it be bleeding, whether it be infection from the neutropenia. And so we just need to kind of revisit those things and allow ourselves to, well, acknowledge the grey, I guess, and do our very best to make the best decision we can in the moment.
Thank you. Mara, would you also weigh in on your thoughts about this patient's candidacy?
Yeah, thank you. Certainly shows your case as well. They're all difficult. I think here with just thinking about the outcomes for leukemia generally, and the outcomes are getting better and the treatment's getting better. And because it's now so good, I think there will be more children that when they fall into difficulty will be referred for ECMO consideration. And then it's thinking about that candidacy. If we don't advance treatment or be innovative in the way that we think, it is hard to move things forward. So, you know, one of the speakers was saying earlier that, you know, 10 years ago, this would have been a definite no, and we wouldn't even be here discussing it. But now it's on the table and it is a discussion, and we think about what we can do and the difficulties that we may face when we're doing it. I think it's been open and honest with the families, really being transparent about the difficulties that we may face with providing ECMO support in this patient cohort. And it is a multidisciplinary decision, and remembering everybody in that decision, and, you know, the nurses at the bedside as well that will be talking with the families that are there for a number of hours with them. So coming back to this child, it's weighing up the burdens and the benefits for offering treatment. For offering treatment for a respiratory reason, I think if you go into it, that everybody knows why you're going into it and that you have an exit strategy, so that you maintain your team dynamics as well.
Certainly setting expectations and discussing exit strategy are both crucial. Dr. Roeleveld, I want to come back to something you mentioned earlier about making ECMO candidacy decisions in a group. You mentioned that this is one approach you would take. Does your institution have any formal protocols or processes around ECMO candidacy? Can you hear me, Dr. Roeleveld? We will go to Dr. Moynihan. Does your institution have any processes or protocols around making ECMO candidacy decisions? And is it made in a group or by an individual?
We definitely strive to have interdisciplinary discussions where time allows, and even in the urgent cases, at minimum, even when we're doing CPR, I would at least have a conversation with a cardiothoracic surgeon or a cardiologist, or ideally both. So yeah, we definitely strive to have an interdisciplinary collaborative discussion to think through ECMO candidacy to make an individualized, considered decision for that patient at that time.
Dr. Roeleveld, it looks like you are back. Did you want to weigh in on this question?
Yeah, I'm sorry. I just had an urgent medical question and problem to deal with, so I've missed the last 5 minutes. So I'm gonna skip
No
a little
worries.
bit if you don't mind. Sorry, I apologize.
No apologies necessary. Dr. Heimbach, would you like to weigh in on the process utilized at CHOP for making ECMO candidacy decisions?
Sure. I think we have 3 units that provide ECMO in our institution: the NICU, the CT, the cardiac ICU, and the pediatric ICU, and each is a little bit different. I think all of them have sort of ECMO resource people who sort of think about these things maybe more than other people, and know some of the literature better. And then in the cardiac ICU, they're certainly really good about identifying particular cardiac lesions or particular post-op surgical patients that are certainly candidates, and they're actually really good about putting that in notes. And I think their system of activating that system is very fast. In the peds ICU, or in terms of like the rest of the institution, I think that's not as easily identified. And we do have like general guidance that our intensivists sort of go through in terms of there's like an ECPR activation, but in general, for other urgent cannulations, it's often discussion with the ECMO resource group that's here.
Excellent.
Oh, Katie, I was just going to add in there, just with sort of interdisciplinary discussions and things. One of the other things that we would do within our institution where decisions are difficult is get that second opinion. And we would talk to the other ECMO institutions within the UK just to see if you've got consensus of opinion.
That's a great point. Using resources at other institutions is another very smart strategy. And Elise, I believe we had a few comments in the chat about this case that you were going to share.
Yes, I just wanted to draw people's attention to the chat if you didn't see that. First, I think a few comments ago, Dr. Loftus and Dr. Malone agreed that it's very hard to get true informed consent when, especially like for our first case, when a child was previously well and had a submersion injury, and so that those things are just really hard to actually consent parents when they're in the grips of all the anxiety and fear that comes along with their child being so sick in any situation, really. And then for this patient in particular, Dr. Steiner pointed out that definitely features of her ALL in terms of her genetics, her prognosis, those sorts of things also really need to be considered. We did not talk about those things here just for brevity, but those are definitely part of the multidisciplinary team, and talking, I think, at our institution, having our heme and oncology doctors involved in those conversations. And then somebody pointed out that sometimes these cases can be very, very difficult for the teams at the bedside and the specialist teams, especially if they go on and they're really complicated and have poor outcomes. And certainly, I think Ms. O'Callaghan sort of alluded to that with some of her comments as well. And it looks like Dr. Moynihan dropped a paper for us into the chat for people to look at.
Excellent, thank you. Dr. Heimbach, you have recently looked at the question of how clinicians evaluate patients for ECMO candidacy. This figure illustrates some of the reasons in your study that clinicians quoted for determining that patients were not ECMO candidates. What does the literature that's available tell us about how clinicians are making ECMO candidacy decisions? Is there much literature available?
There's some. I think a lot of it is, or certainly a lot of it is sort of survey based, because it's really hard to study this sort of question, and you often need the individual, and like we're sort of talking about here, you need those individual specifics of situations to like make the fully informed decision, and work with, you know, the multidisciplinary group and families. I think, you know, in general, I think the pre-existent, you know, neurologic functional status is an important consideration that's sort of through all of these different survey studies, as well as like the poor prognosis that may happen, which is certainly what we found too. And I think that's really hard to, you know, predict. That, you know, we talked about earlier, as the longer I've been doing this, the harder it is to predict what's going to happen, and the more sort of less black and white things are, so to speak. So I think the literature is there. And I think there really is a focus on sort of that what people want to focus on quality of life and sort of what they're getting, return patients, not just to not die, right, but also to get them back to where their functional status was at the beginning of the illness, which is sort of where critical care has moved in the last, you know, 20, 30 years in general.
Excellent, thank you. I think we will move to the next case. So now we have a 4-year-old, previously healthy, unvaccinated male who presents to your emergency department with increased work of breathing and fever. You can see his vital signs on the screen, certainly concerning oxygen saturation in the 70s, with some mild hypotension, a heart rate of 175, and fever. He has poor perfusion with cold extremities and mottling. He is intubated, sedated, on neuromuscular blockade, has a large volume fluid resuscitation, and epi infusion and antimicrobials are started. His blood culture is positive for strep pneumo, which is susceptible to the current antibiotics. He has worsening peripheral perfusion and persistent hypotension despite steroids and a second vasoactive with rising lactate. So the team recommends ECMO support to the family at this time, but the family reports that they would like to think about it overnight despite the communication that the patient's clinical status is rapidly progressing. So now we have our next poll. Would you proceed with ECMO cannulation for cardiopulmonary support despite the family's hesitance? We are seeing the majority no. About 30% are saying yes so far. I think while we are allowing a few more people to weigh in, Ms. O'Callaghan, would you share with us how this situation would be handled at your institution in the UK?
Thank you for that one. Again, it's sitting down and it's discussing with the family, being completely transparent, finding out where they're coming from. I suppose one thing in the history was saying that this child was unvaccinated. Is that just something because the change in families' uptake on vaccinations, or is this that they don't really like the medical world or having medical treatment? So, you know, how does that play into their decision making? But what is it that they understand? Do they understand what ECMO is, why we would offer it in the first place? But equally being very open with them that, you know, the outcome here would be guarded. Yes, there's survival, but then equally thinking about the neurology. This child's got persistent hypotension, and how long that's been going on for. So again, talking about the complications with ECMO, that honesty with the family and seeing if
Just
they're
where all the
leaving
access and stuff is. And
are part of the problem as well.
Definitely. Dr. Roeleveld, have you encountered any situations like this in your practice?
It doesn't come across very often that patients or families refuse something that we offer. It's most often the other way around. So this is an interesting conundrum. If I would walk in on a handover on Monday morning, and this is a case that's been going on over the weekend, there's a few questions I would ask as to why we would consider offering ECMO in the first place. I think that's debatable in sepsis patients anyway, but let's say they, and I assume that the team has made a good decision based on their experience and based on the aspects of a poor cardiac function. So let's say that yes, I would also offer this patient ECMO, and then parents refuse or want to wait. Then I would go and talk to them and discuss and try to tell them and convince them what my thoughts are and my beliefs are, and then presenting it for the team, so not just mine, but team-wise. And I would, talk to them. I've never been in a situation where I would have to, what's the word in English? There is an option to legally force it upon them by taking away the parental rights for a little while. I've never had to do that, and I hope I never ever have to do that in the future, because I think that creates a enormous conflict and a court order. Thank you. I would discuss with patients, with the parents, as to why, like Maura said, why are they refusing? Why do they need to think about it? And try to explain to them as good as we can what our convictions are about this. I do wonder why 72% of the people, of the audience, said no, and if that's pure because the parents say no, or is that because they have already some reservations towards ECMO in sepsis, as I personally would have in this case. But I don't think we can answer that question. But I would talk to parents and take them along in our thought process and our decision making, and say that we both want the same thing, and it's the best outcome for their child, and try to convince them of our goals.
Yes, you bring up some very interesting points. Dr. Moynihan, you looked like you might have something to say about that.
No, this one's super hard. So like overriding parental decision making is a pretty, murky area. And I think, as everyone's already alluded to, the first step here is to really explore their thinking in terms of what they're actually refusing, and if they really do understand why in the medical team's risk benefit estimation it is going to be beneficial for the child. I think, to override parental decision making here, there needs to be substantial harm, which arguably you could say there could be if there is progression despite maximal other therapies. And then there also should be a reasonable degree of certainty here that our therapy is going to help. And is ECMO in sepsis really standard care? And that's the question. So I think that's probably why we're seeing a little bit of the yes/no swing there, because it's probably, as Pete alluded to, not technically considered standard care, although it is, on the list of the escalation plan. And so it's a hard area in terms of overriding parental decision making, certainly at least in the US, where there is a great deal of deference in that regard. But the first step, as everyone's already discussed, is to really drive down into the why.
Certainly. Dr. Heimbach, anything to add?
No, I mean, we had not a dissimilar case to this a little while ago where a child had critical pertussis, non-immunized family, and had horrendous pulmonary hypertension related to the hyperleukocytosis and everything that goes along with it. And, had sort of escalated, and we recommended ECMO. And I think the child actually even got into the operating room when the family, in consultation with their other members of their families, thought that it was not the right thing for their child. It took a while to sort that out, but it was the right thing, and the child survives at home, and no oxygen. It's fine. So, always you think that what you think is the right thing, and sometimes it's not necessarily the right thing, and I'm always humbled by that, for sure.
There is so much gray area in what is the right thing. You can advance to the next slide, Elise. Dr. Moynihan, in your paper on ECMO candidacy decisions, you describe the robust decision-making process and for the beneficial use of ECMO. I've included your figure. Do you have anything to add about this process? I know we've mentioned it a few times, but I wanted to include this nice figure.
Yeah, the kind of premise behind this is that, as we've just seen, like every clinician or team might make a different decision given at least similar clinical scenarios, and everything has to be pretty individualized to the specific case that we're dealing with. And so in light of that, the fact that there is a huge amount of variability between what we may decide in one moment or another, and the fact that every child and family does deserve a fair and well-considered decision about whether or not ECMO is the right thing to do, then I think myself and the authors on this paper have really advocated for a structured process-based approach to consider a patient whether or not ECMO is going to be beneficial. And so the kind of underlying reason behind that is that while we may have differences of opinion as to whether or not the patient should be cannulated or not, most people can agree on what are robust processes and principles that make a decision a legitimate one. And so if by following a set of steps, we end up with a decisional output, then even if you disagree with what that output was, or you wouldn't have made that, you don't think you would have made that determination at the time, then you can mostly align with the decisional output because you can align with the legitimate process that led to that decision. And so part of these are pretty standard steps that we've all really talked about in terms of like getting an interdisciplinary group of stakeholders together and things like that. And so that's not, rocket science to think about how we make decisions. But I think, acknowledging that gray and the huge amount of prognostic uncertainty that we're dealing with, if we can have a structured process where we are open to discuss the options, incorporate the family values to make our decision, and have it open to appeal and dynamic to the patient's clinical status, then we can align better with whatever decision is made when we're not actually involved in part of that decision.
Excellent perspective. We can continue with the case. Please, one more slide. So this patient progresses. His hypotension and perfusion worsen with signs of digit necrosis. Pupils become unreactive with minimal urine output, and the family decides they would now like to proceed with ECMO. So I think we have another poll for the group about, given his change in clinical status, whether you would still be willing to offer ECMO to this patient. And certainly some early no's with his, and a few yeses. And I think we can go ahead and have our some of our panelists weigh in on their thoughts in this case. And while you are telling us whether you think this patient would still be an ECMO candidate, please comment on whether there are any conditions that you feel like would be a contraindication to ECMO in general, not just this patient. Dr. Roeleveld, you unmuted.
I think that if we spoke to the parents for a long time, and we tried to explain to them why we would consider ECMO, and I think let's assume that we came to the conclusion that yes, they do understand what ECMO is, and they still don't want to do it. And we also have uncertainties about the indication in this child with sepsis. Then, and if the child will then progress, and then suddenly the parents start to realize really that they're losing their child, and then I think it's too late, probably. And we would not offer it again for the parents' sake, because it all should always be for the child's sake. But that's, again, difficult to assess. If we really feel strongly that this child is a good ECMO candidate, and we were able to convince parents by talking to them that this is the case, and they just needed this extra, then they needed this extra time and maybe deterioration. And the question is, how much has this child deteriorated? With unreactive pupils, I think probably also beyond a fair indication. So, but if, let's say, the child still did have reactive pupils, and just a little bit of digit necrosis wouldn't keep me from offering ECMO then. But the unreactive pupils and a probably very septic child with a high lactate, I would not offer it again. But it all depends on how you spoke to the parents and what you decided with them, and how much deterioration is deterioration. But in this case, I would say no, unreactive pupils and this indication.
Yeah,
But I would still talk to the team.
definitely. I think we have a large consensus here towards no, so maybe we move to the next case since we have about 10 minutes left. And I'm very curious to hear some opinions about this one. This is a 1-year-old female with a past medical history of trisomy 18 and a VSD who presents with tachypnea, fever, and poor PO intake for a few days. She is desaturated upon arrival to the ED. High flow nasal cannula is initiated, but eventually requires intubation and mechanical ventilation. She's found to be RSV positive with worsening respiratory failure consistent with ARDS with an OI of 42. She has stable cardiac and renal function. So we have a poll for the group. Would you put this patient on ECMO for respiratory support despite her life-limiting genetic condition? And I think we can go ahead and have Ms. O'Callaghan, would you like to weigh in on your thoughts about this patient's ECMO candidacy?
Yeah, so having a read through this, so with this patient, I think we would be offering ECMO support. I think we'd get as much information we can about her past medical history in that 1 year. So where is she at 1 year? What's her where's her development? How well has she been in that year? And is ECMO the best thing for her? Does it, benefit her? And if we're treating the RSV and the ARDS, then I think as an institution that we would offer it with that extra information. And obviously there you're going to have your investigations like your chest x-ray and your echo and things, and take that careful consideration again about talking about that as a multidisciplinary team, discussing that with the family, and maybe getting second opinions as well.
Excellent. And it looks like the majority are saying yes here. I think Dr. Heimbach, what are your thoughts on this case?
I think, we all have these pre-existent, notions of these certain diagnoses, right? So trisomy 13, trisomy 18, other, profound developmental delay for whatever reason. But I think, where I think have changed or shifted, at least my view, is just that functional piece of things, right? The functional aspect going into illness, not actually the specific diagnoses. And I think that's something that's sort of borne out in what we're talking about is, having a sense from the family, having a sense from the caregivers, where that child is, and if we can get them back to where they are, if that's a good quality of life for them. It may not be one that we choose, but it may be the right right for them. And so for this patient, I think for sure we would, a single organ disease in a child with a developmental delay, we would definitely put them on.
And while we have you, can you tell us about this figure from your recent publication about clinicians taking functional status into consideration in their ECMO candidacy decisions?
Yeah, I think we tried to take a little bit of a different perspective as opposed to hypothetical situations and giving hypothetical situations to as a survey to experts to see what they thought. What we tried to do is take clinicians and put them in clinical situations where they were taking care of patients, and then hypothetically ask them to whether or not they consider ECMO for this particular patient, this particular situation. And so I think we tried to use that perspective to get at how the functional status of a child going into illness, or what factors going into illness would play the biggest parts in the decision making for a clinician, for intensivists specifically, to decide if patients are candidate or not candidate for ECMO. And what we found was really for those, and we used an objective measure, the FSS score, which is an objective measure that was on admission by research nurses that actually did that scoring. And we saw that if you are a patient who had severe dysfunction as characterized by FSS scores, then you had a much less odds of being considered an ECMO candidate, which I don't think was surprising to us. I think what was surprising was that I'm not sure that was, you saw that figure before where people really quoted, they said, the prognostic piece was why they would consider people not to be ECMO candidates as opposed to other pieces. And it's all together, it's all related, but I think it was interesting, just a little different perspective on what's been published in the past.
Dr. Roeleveld, what would your thoughts be on this patient's candidacy in the Netherlands?
I totally agree with Dr. Heimbach, but I do know that it will be a significant discussion in our country. I think we still have a notion that trisomy 18 is a absolute contraindication. So it would take some convincing and talking, but it's all about how we assess the pre-admission quality of life, and can we get the patient back to that. But we are very restricted towards trisomy 13 and 18. And I think probably maybe a little bit old-fashioned still, but it would be a big discussion. But I agree with the previous panelists, and I would probably offer it to this patient.
And along those same lines, are there any conditions that you maybe considered contraindications in the past, but do not consider contraindications to ECMO currently?
Well, we said a definite no to oncology patients and post-stem cell transplant patients. And I'm not saying that we do all of them now, but we have started thinking about it more properly. And the paper that Katie put in the chat is a great guide to help you in your decision making. It's still based on limited amount of evidence, but it does show you that if you have a good indication, and if you talk about it amongst your team, then you can reach good outcomes in very selected patients. But SCT, post stem cell transplantation, is not a definite no anymore, and it used to be. I think for me that's the main group that's changed over the last 10-15 years.
Dr. Moynihan, same question. Any conditions that were previously absolute contraindications that you would not consider contraindications currently?
I'm in a unique position because I kind of lived and worked in Australia 10 years ago and now work in the US. So things have definitely kind of changed in terms of my clinical practice. But I think in this particular case, it's worthwhile saying that clinicians are notoriously bad judges of quality of life at baseline. And so I think, what was said by Mara at the very start, that, we really, if this is a kid who's been in hospital, frequently with terrible lower respiratory tract infections, and then we have a different conversation with the family than if this is the first presentation from a potentially reversible problem with RSV pneumonia. And so I think a genetic diagnosis or a singular neurological problem alone is not a reason to make a patient not an ECMO candidate. I think we just, at the same time, not every child's path to death should be with ECMO, and so we just need to have these conversations and think about it in a way that makes the best decision we can for the patient in the moment. And so I think indiscriminate use of ECMO, like it being a default option for every single patient, is definitely not the right way to go. We just need to be thoughtful about it for that individual patient.
Excellent. I think we will move to the last case. We will go a few minutes over, so feel free to hop off if you need to. This last patient is a 14-year-old female with asthma who presented from an outside hospital. Initially had respiratory failure requiring intubation in the setting of flu A, but had a cardiac arrest at the outside hospital, was cannulated to VA ECMO and brought to your institution. After 60 days of support, she has shown little improvement with persistent lung collapse, has developed multiple complications with a hemothorax, a large bronchopleural fistula that has been persistent, as well as GI bleeding requiring daily transfusions. So the medical team is questioning the utility of continuing ECMO support at this point. And we have a poll for the audience about their thoughts on discontinuing ECMO support at this time. And we will go to you, Ms. O'Callaghan. What are your thoughts? How would you approach this case?
Yeah, again, another difficult case. I think, just this child being 14 years of age, I think makes a difference to the family, and I think the team looking after it. This is a child that has a place in that family, and 14 years of that, so you've got all their friends and everything else to take into account. But this is very difficult, and I think if the medical team and the nursing team are questioning the utility of continuing ECMO support, then you have to be having those discussions about discontinuing ECMO if that's the right thing to do. And that's having those discussions with the family about trying to get consensus. One, is there consensus within the team themselves at the very beginning? Those discussions then with the family and about the difficulty that may come with trying to pursue continued support. Thinking about, for families, sometimes they need to have a little look about not just life on its own, in its own entity, but what are the benefits and the burdens for this child as they go forward if you were going to try and get them off of ECMO support. Timing can be a really difficult thing for that family, because sometimes the medical team or the nursing team can get there and make those decisions before the family, and sometimes the family are there before us, but it's getting the timing right so that we can sit down and maybe plan that if this is truly futile, how the end of this child's life would be and how that could be planned. And they may need time to discuss that. Like I said earlier in one of the other cases, that would maybe getting second opinions, that the family may want that second opinion, that we may think we can't support this child any longer, but could another institution be able to do that? Or are there other experts out there that would keep this child alive? So second opinions, they may need advocates for themselves to put their side of the story across and what they want. And that could be chaplaincy. For the team themselves, if we're not in consensus, it may be going to the ethics board to find out if ethically it is right to keep ECMO going or whether we should be stopping. And if things got very, very difficult, you may have to go down a legal route if the medical team thought that we should stop, but the family thought that we shouldn't. That's very much a last resort. It'd be very much a last resort within our institution. You would want to bring the family with you. But knowing that at any time, this decision can be just taken out of our hands by the child's condition. And I think being aware of that. So if discussions go on over a number of, that could be minutes, hours, or days, it may be taken out of our hands. But if you can get that shared decision making, and you keep the family with you, and make even though this is a desperate situation, that you make it the best situation that you can for the family, because could be their last memories.
I think you elegantly stated many of the things that we strive for in these situations, and it seems like in the chat, Dr. Ruhleveld agrees. Dr. Moynihan, this is an excerpt from your paper where you also comment on some principles for ECMO discontinuation. Do you want to elaborate on anything here or anything that Ms. O'Callaghan said?
Yeah, I think Maura said it perfectly, to be honest. I mean, these situations are rare. Most of the time with therapeutic relationships and, collaborative, high quality communication, and we can get there with most families. There is definitely, increasing societal awareness of ECMO. There is this kind of increasing kind of mistrust in some forms of medical decision making. So I do think that conflict is probably coming, and so having some processes to deal with disagreement. But I hope these are rare, and most of the time we can get there together. As part of this, I mentioned that there's kind of a process. I've advocated for a process for making these types of decisions, and that we need to continually revisit those decisions. And so as part of that, I think an element of documentation is critical. And so when we go on ECMO, it would be useful to have documented the reasons why we went on, and early on in our conversations with families, highlight kind of milestones that we're hoping to hit along the way. And if, either the milestones are not being hit, or if we have certain complications, then we would revisit regularly whether or not ECMO is beneficial. And so that should be kind of iterative conversations frequently. And it may well be that, as Maura perfectly put, like sometimes the family gets there and perceived burdens, and the medical team is, still hopeful or still perceives a path. And it may well be that the medical team no longer sees a path, yet the family are still hoping for things. And so trying to get us both on the same page at the same time really is only going to work with high quality communication and frequent conversations about benefits and burdens and what we're seeing, and ensuring that we are all transparent about what goal we're trying to get to.
Also very eloquently stated. Dr. Heimbach, does your institution have any sort of policy or criteria for ECMO discontinuation in the case of futility?
I don't think there's not any like formal policy or, I think we have obviously interdisciplinary discussions. I think one thing we've had success with in the pediatric ICU, and I think in the cardiac and the NICU too, is sometimes we're able to have sort of the longer term, higher risk patients have, nurses that care for them more frequently, in terms of like a core set of nursing, a core set of physicians, or a physician that takes sort of the lead on their care. And I think that sort of can help too, in terms of, exactly discussing, here we're on ECMO for this reason 6 weeks ago, 2 weeks ago we're here, and now this is or is not sort of what we think should be happening in the situation. So I think that helps too, in terms of that consistency of message. But there's definitely not any strict criteria or anything like that.
Thank you. You can go to the next slide, Elise. I think that concludes our cases. A huge, huge thank you to our panelists for being so open with us throughout these cases and giving us your expertise. Please fill out our evaluation with the QR code if you're able to, and if you did not claim CME credit, feel free to do so at this time using this code texted to that number. And my sincerest apologies for the technology difficulties early in the presentation. Thank you for hanging in there with us. We are over time, so we unfortunately do not have time for additional questions, but thank you all so much for your attention, and we hope to see you at the next webinar.